Dr. Suresh Kumar, Consultant Medical Oncologist, Kaveri Hospitals, for a talk on immune-related adverse events and efficacy from the phase 3 trials, iEMpower 130, 132 and 150.
Thank you, Dr. Hollis. At the outset, I would like to thank the organizers for giving me this opportunity. I'll talk about the pooled analysis of immune-related adverse events and efficacy from phase 3 trials, iEMpower 130, 132 and 150. So background, immune-related adverse events are a common off-target immune activation seen in about 80% of patients who received immune checkpoint inhibitor therapy. And also it is seen about 95% of patients who receive combination immune checkpoint inhibitor therapy. Increasingly, evidence suggests that the occurrence of immune-related adverse events with immune checkpoint inhibitors may be predictive of improved outcomes in patients with cancer such as NSCLC. Atezolizumab has shown efficacy and tolerability in patients with lung cancer and is currently approved in both first line, second line, and beyond settings. So in this pooled analysis, we'll see three trials: iEMpower 130 and 132. Both these trials evaluate the safety and efficacy of ATEs in combination with chemotherapy in first line, and iEMpower 150, which studied atezolizumab plus chemo plus Bev in the first line setting. So this is a pooled analysis of these three trials: iEMpower 130, which studied atezolizumab plus nab-paclitaxel-carbo versus chemotherapy alone, that is a nab-paclitaxel-carbo in first line setting. The iEMpower 132, which also studied atezolizumab plus different chemotherapy backbone, which is PEM-carbo or PEM-CIS, versus chemotherapy alone, which is PEM-carbo, followed by maintenance chemotherapy or immunotherapy. And the iEMpower 150, which also studied atezolizumab plus chemotherapy plus bevacizumab in first line setting, and this study also included EGFR and ALK treated patients. So this is an analysis plan of this pooled analysis. So in this, the three trials have been taken. Totally 2,503 patients were there. It is divided into two arms. One is that immunotherapy containing arm and the control arm. The immunotherapy containing arm is further divided into patients with immune-related adverse events and patients without immune-related adverse events, and which is further categorized into grade 1 to adverse events or 3 to 5 adverse events. So the demographic characteristics were similar in all the four arms. That is atezolizumab with or without adverse events, and control arm with or without immune-related adverse events. Majority of the characteristics are similar between all the arms. The only difference is the ethnicity. The Asians were relatively higher, which is about 18% in patients with immune-related adverse events in atezolizumab arm. This is a summary of immune-related adverse events. We can see that any grade immune-related adverse events are higher, seen about 48% of atezolizumab arm, versus it is seen only about 30 patients in control arm. Other side effects like rash, hepatitis, hypothyroidism, and pneumonitis are also commonly seen at a higher rate in patients who receive ATEs arm. The incidence of grade 3 to 5 adverse events like rash and hepatitis are relatively low, which is about 2%, 5%, and like that. Other rare immune-related adverse events include hyperthyroidism, colitis, infusion-related reactions, adrenal insufficiency, and pancreatitis. So if we see the survival according to the presence or absence of adverse events, we can see that patients on the atezolizumab arm who had immune-related adverse events have a significantly higher median survival, which was about 25.7 months, when compared with patients who did not have any immune-related adverse events, which is about 13 months. Similarly, in the control arm, we can see patients who had immune-related adverse events also had significantly higher survival, which is about 20 months versus 12.8 months. Based on landmark analysis at 1 month, 3 months, 6 months, and 12 months, we can see that in all these points, we can see patients who had immune-related adverse events with atezolizumab have a significant higher survival when compared with the other arms. The same thing. So atezolizumab arm patients who had adverse events had significantly better survival at all the time frames, at 1 month, 3 months, 6 months, and 12 months, which was statistically significant. If you look at the overall response rate according to the adverse events in patients who are on atezolizumab arm, patients who had immune-related adverse events had a response rate of about 61% versus 37%. Similarly, in the control arm also, patients who had immune-related adverse events have a higher response rate of 42% versus 34%. Similarly, if we look at the various time points and characterizing the grading of adverse events into whether grade 1 or 2 or 3 or 5, or patients who did not have any adverse reactions, we can see patients who had grade 1, grade 2 adverse reactions, immune-related adverse reactions, are significantly better survival at all time frames. However, if you see patients who had grade 3 to 5 adverse reactions, they had a worse survival, possibly because of treatment discontinuation. Patients who had grade 3-5 reactions have poor survival. The same table depicting that at all the time frames, patients who had grade 1 to immune-related adverse events have a better survival, which was statistically significant, when compared with patients who had grade 3 to 5 who had worse survival. So this is the grade 3 to 5 immune-related adverse events in the landmark subgroups in the ATIS arm. The most common immune-related adverse events is hepatitis, which is seen about 52% of patients at 1 month, and also it's the most common adverse reaction at all the time frames. The other top 3 immune-related adverse reactions include rash, pneumonitis, and colitis. If we look at the treatment disposition, we can see patients who had grade 1 to immune-related adverse reactions. 75% of the patients were withdrawn from the treatment, and among that, 14% was because of adverse reactions.
Suresh, I request you to conclude in the next half a minute.
Yeah, I'm concluding, sir. So conclusions. So in these exploratory analysis of IMPAR 130, 132, and 150 trials, patients who experienced immune-related adverse events show longer OS than patients who did not experience these immune-related adverse events. The overall survival hazard ratio from the time-dependent Cox model in the ATIS arm was 0.69. And patients in the ATIS arm containing arm with grade 3-5 adverse reactions had a shorter OS than patients who had grade 1 to immune-related adverse reactions. Similar to all the time frames, we can see patients who had immune-related adverse events had a significant longer survival. So data from these analysis suggests that there is an association between immune-related adverse events and efficacy in patients with NLCLC, and further support the use of atezolizumab combined with chemotherapy with or without bevacizumab in the first-line settings. Thank you.
Thank you, Dr. Suresh.